Hello, everyone out there on the web and sitting wherever you are. As you can see from the screen, there are a number of people here presenting today and sharing thoughts with you in this webinar. It's called Perspectives on Evidence-Based Design, a question that is recurring in the debate and in the practice development and the research. And we will share some perspectives here today. The people joining us here today is, apart from myself, Göran Lindahl from Chalmers, and my colleague Ásgeir Sigurjónsson, are Mike Apple from HDR and practicing architect in the US, Anåker and Marie Elf from Dalarna University, and Andrea, Brambilla and Stefano Capolongo from Politecnico di Milano. Each of them will present themselves briefly in their presentations. So you'll get more of them, and we will meet up again at the end after these presentations to have a discussion on this topic in the end. So yes, first let me take you into a short introduction of CVA, and then Ásgeir is going to talk a little bit about the report Evidence-Based Design 2020, a report you can download, and the report of which, well, most of us here on that panel have been also active in producing. And then discussion at the end after the presentations and input from each speaker. So again, warm welcome to this seminar on evidence-based design. My name is Göran Lindahl. I'm director of the Center for Healthcare Architecture, a center focusing on development and dissemination of knowledge around the physical environments of healthcare and health-related issues. We are active in teaching, research, development, and collaboration with the healthcare sector and its stakeholders. And it's a role we've been having since 2006. And some of the key aspects is that we try to act as a national arena, collecting and disseminating information and R&D. We also maintain a academic continuity from workplace research from the 1970s. So we have a sort of firm position here in the Chalmers Academy. We also teach on the master's level in healthcare design and residential healthcare, which focuses on care in people's homes. Issues also important to Marie and Anna. We also node in a Nordic collaboration within a couple of other universities, among them Aalto in Finland, SB in Denmark, NTNU Norway, internal collaboration with other units in here at Chalmers. We also initiated once the Arch Conference in 2012 here at Chalmers, and the next one is actually, after having been in Norway and Denmark and Finland, is back to Sweden in 2026, so keep looking for the information on that conference on our website. And one of the kind of things that we do is the reports. These are so-called concept programs that provide guidelines for design, as we have a deregulated planning in Sweden with basic norms and standards only. These documents are there to guide planners and architects and designers on how to, or rather to where to start when designing healthcare facilities, given the context in Sweden. These are all downloadable from either Chalmers or PTS, and you can see the logotype there on the slide. The report we're going to talk more about today, and of which Ásgeir is going to talk about a little bit more in a minute, is the evidence-based design report, which came out, the first one in 2012, called Evidensbas för vårdens arkitektur, which basically was a way of assembling what is the current status of evidence-based data and results in research papers and reports that we can gather that could be of use for those that design healthcare facilities and hospitals and caring facilities. It was then updated, and with the year 2020, Maria, Anna, Ásgeir, myself, and a few more were engaged in that work, and it was again in Swedish. But there's also then, after having discussed with ourselves, an English version, which you also see now on the screen, and that forms the basis for today's session, and that report can also be downloaded from CVA website. And having said all that, I'm going to hand over to you, Ásgeir, and you talk a little bit about what kind of report is this, Ásgeir?
Thank you, Göran. Yes, so as Göran said, the report is can be downloaded from the website of the Center for Healthcare Architecture. We're going to show a link in the end of the slideshow. So if you can go to the next slide. So why and what is it about? The why, there is an increased awareness of the impact of the built environment related to effects on healthcare qualities and effects. And requirements have increased on designers to utilize research when designing. And the what, so the report communicates relevant research results to anyone involved in designing or making decisions about healthcare physical environments. So the report summarizes research on the physical environment's impact on patients, relatives, and staff. And if you look at the next one, so the report covers the following themes: single occupancy patient bedrooms, patient safety, daylight and artificial lighting, work environment, orientation and wayfinding, positive distraction, nature and gardens, sound environment, and attractiveness. And these themes were identified in the previous report written by Roger Ulrich as the most important areas and where evidence-based design can have the most effect. It's good to be aware of when reading the report that this is also the frame. This is also a limit. So if there would be a study that would not touch upon these areas, it would not be in the report. And a bit more about the limitations that is good to be aware of on the next slide. So that we took in, it was a very broad systematic research of a collection of reports that studied outcomes on patients, relatives, and staff. If there would, an example of an excluded outcome is if there was maybe a study on the economy of the hospital as a whole, then such a report would not have been taken into our study. And we included only articles from peer-reviewed journals, and this was from the publication dates 2010 to 2019. And it's good to be aware of that we did not include nursing homes, long-term care facilities, and in-home care. This was a decision since we did not want to have too much material, and just, yes, as it's a part of a systematic study, all the limitations are very clear and very important to be aware of. And that was my last slide to talk over. So I will hand the word over to Mike Apple.
Great, thank you. I'll start sharing screen here. Good.
Okay, good, Mike. You take over and give us.
I think you have to stop. Okay, there we go. All right, let me know when you see it.
We see it.
Great. Well, thanks. I'll give a quick background so you guys know where I'm coming from. I'm a practicing architect. So I work with healthcare planning, research, campus planning, design development with medical equipment. So all kinds of spectrum for inpatient and outpatient facilities. So I'll share for a few minutes some examples of my perspective on how to incorporate research evidence into this process. And for me, I think it actually started back around 2008. My colleague and I studied for a project, Cleveland Clinic, Abu Dhabi, we were working on, and Roger Ulrich and his team had just published their literature review. So we tried to figure out, what does it mean, single patient rooms or hand washing stations or overhead patient lifts for safety, the patient hoists. So started to explore those things, and it's complex. So I'll share some ideas about that today. I think the starting point is, as we as architects, designers, believe that design matters. It has an impact. And what we do may have an impact on things we might not even realize, and impacts may be multifaceted in a way that as designers, we can continually think about who we are designing for. Now, these impacts can be complex. The building location or flexibility or whatever design strategy you're doing, does it affect patient well-being or does it affect the natural environment? It probably affects many of those aspects and even more that are off the screen, not even listed. And then how do we know a design strategy? We have some good intuition. We learned about that from Roger Ulrich discussions with Stefan Ludin, and about what is this intuition that can lead to good results, but there's also some uncertainty. So how does evidence play a role in this? And the peer-reviewed research reviews that were EBD 2020 is a great resource for that. But it becomes even more complex about this evidence. How do we implement it into our design projects? If research evidence is from Sweden, is it applicable in Australia? Maybe. If it's evidence about an oncology inpatient unit, is it applicable to an orthopedic inpatient unit? Maybe. Is the evidence statistical significance, the good statistical analysis, or is it more of a qualitative or anecdotal that's not as reliable, possibly? Is it evidence from 10 years ago? Is that still applicable? Maybe. So all these things we need to consider together holistically. And so part of that is the evidence quality, as I mentioned. As architects, we don't have a lot of training in that usually. Sometimes with the EDAC certification, EDAC, that helps a little bit. But it's important for us to be aware if we have a vendor or a magazine telling us something, it may be valuable, but it's a different weight of credibility than some research studies that would be more on the right side of the spectrum. And then for us in practice-based approach, and when we're doing the design, we may have clinical user focus groups with nurses and doctors. We may have surveys or questionnaires to them even. We might do mock-ups of the bedroom or the operating room out of the cardboard, and we can do some simulations and get some evidence type from there. So there's a lot of ways, different types of evidence that we can incorporate and put together to get a design strategy that's resulting. And then after occupancy, when people start using the new healthcare facility, we can again do clinical focus groups to see how is it affecting their work or how is it affecting the patient experience. We can tour it, we can collect even some data, and that can be published in a peer-reviewed journal or a magazine or conference. And then there's a continuous cycle, hopefully, as we're continuing to improve our design over time. But it's complex with the layers of indirect impacts. For example, if we have a design strategy to have an open nurse station, it might affect the staff to patient visibility, how you can see the patients, but it affects other things too, etc. So there's these layers. If our eventual goal is we want to reduce patient falls or we want to increase staff satisfaction, our design strategy probably will not directly impact that. We have to consider the context and the variation of the layers along the way too. So there's also often a tension of we want one goal, but it might be in conflict with another goal. If we get better visibility for the nurses, does that mean we have less privacy for the patients? And so there's lots of factors that go together, and how do we weigh against those or prioritize those, or ideally have a flexible design solution that can accommodate both. And so it takes a lot of collaboration among multiple disciplines to achieve that. And it takes good buy-in from the hospital client to clarify the priorities so they don't change along the course of your design, hopefully. So when we look at what are the basis of design decisions, traditionally we often do it from our experience. And if you're experienced for many decades, you have a lot of great experience that you've collected over time that can usually create some good designs. And then also you probably have a lot of overlap with whatever evidence or best practice information is. The longer we practice, we can gain that. But it takes a little bit more proactiveness to get that research evidence incorporated also. But putting all these things together, even the regulations, which sometimes are evidence-based, can create a good result. For a design decision, we have many design decisions. Each one we can work together to create a thoughtful and impactful approach. So I'll share a couple findings, two here from the EBD 2020 report, which you can download from the website, as he mentioned. And this one is for nature. We know there's a lot of good evidence for nature and for daylight. And for this one, here's an example project I did recently. And we do this commonly for MRI rooms because the procedure may be 45 minutes and could be stressful. But we rarely do nature or image ceilings or artwork, music for CT scanners or operating rooms or endoscopy rooms. So I thought there's an opportunity here I can learn from, but it also takes a complex correlation between what's the cost, the construction cost versus the outcomes you want to achieve. This is my favorite actually, EBD 2020 report finding that nurse communication and laughter increased when they were in rooms with windows. I try to keep advocating this in the US, we need more windows. Well, apparently laughter increases when you have windows too. And a couple studies that we've been looking at recently, this is in US and England has been looking a lot at this too, about nurse station decentralization. If traditionally with a paper medical record, you have one big central nurse station, but now with medical records electronic, should you decentralize? So there's pros and cons. The evidence is not that great actually. So recently, we've done a couple of literature reviews on this in 2020, 2019, and our current design approach is sort of a moderate or hybrid approach to try to achieve a balance between the factors. So maybe further research will be helpful for this, but also it's complex. So the best design may depend on your setting. And then related to that is visibility across the unit and affected by decentralization. But as we have more offstage corridors for robots or staff, how does that affect the visibility? It affects the amount of space and the cost also. So that's another topic we've been discussing that has little evidence, and sometimes we have to create our own evidence on that. So lastly, I'll recap that I think it's a never-ending pursuit of evidence, of excellence, because our goal is to design excellent places for people to work, for people to receive care. And there's all these different sources, including this report, which we're talking about today. One of my favorite sources is the Herd Journal. There's some of them are open access. Sometimes you may have to subscribe or pay for it. But all these different sources of information, we pull them together, like the colored ball with the wires. We pull information together, we sort of synthesize that. And in fact, it's not unlike what we need to do in our culture today with news and information coming from all different sources and even AI. And how do you filter that to figure out what is true, what is most relevant for my project, and put that together? So in recent projects, for example, we got some evidence about rehab inpatient bedrooms from the client because we toured the last facility. So it's very practical for us. And for another recent example, for outpatient surgery centers, they looked up how do we increase throughput for those. They looked by the hour for some peer-reviewed journals. I found some information, but it's very hard to find anything for design related. It was about operations related. So it's still a challenge, but we continue to work together to achieve that. And we'd be glad to coordinate with y'all as we do this together, because sharing the knowledge across companies and across countries really helps increase it too. So that's the experience background. I look forward to the next portions too.
Thank you, Mike. Very interesting. Good to have your perspective here. Let's move to another spot on the world. Let's move to Anna and Marielle's presentation. Over to you, Anna.
Thank you very much, Göran. My name is Anåker, as you see here, and I'm a nurse with a PhD in medical science, and I'm working at Dalarna University together with Marielle in the panel. And my research area are, of course, this area that we are talking about today, the healthcare environment, but also climate change effects on healthcare, not at least those days. I will present results and comments from our paper, Systematic Review of Research Gaps in the Built Environment of Inpatient Healthcare Settings. And here you have the paper. The paper was published in Herd only, I think it was 4 or 5 months ago. And in this group of people that you see here, we have been working together, and we represent a wide range of countries and also professions. We are from Canada, Sweden, Netherlands, and Australia. And we are nurses, and we are architects, physiotherapists, occupational therapists, and not least from the field of health geography. And I will start with some background to this paper, or should I say this project. As Göran told us in the beginning of the webinar, it all started, I think it was 6 or 7 years ago at Chalmers Center for Healthcare Architecture. And together with Professor Roger Ulrich, some of us started to work with EBD 2020, the report that we have seen today. And after the Swedish report, the report now translated into English, we continued the work and started with additional search and ended up in 2022 with a huge number of articles. And we wanted to do something new with this paper. We had the influential work of Roger Ulrich and colleagues, and that work has been instrumental in shaping the understanding of how healthcare environments promote health and well-being. And they, in that report, identified critical design elements, such as single rooms, atmosphere. You saw the words, the areas in Ásgeir's presentation. It was the natural sunlight, view of nature, navigation. And I think after that report, the very first report by Ulrich, the research field exploded. And all research and other reviews after that typically concentrate on a specific setting, outcome or population. For example, if you think about the physical environment and stroke rehabilitation. So we have a lot of research, we have a lot of reviews, but our study utilized the evidence gap map method, and we examined the scope and the methodologies and focuses of the studies that investigate the influence of the built environment on inpatient healthcare settings over a decade. And as I said, we used the evidence gap method, EGM, which is a systematic approach to summarizing and not least visualizing published evidence in a specific field by identifying research gaps. So the most important for us, well, that's to see the gap, and I will come back to that. And we organized around 4 central teams. You see them in the bottom here. For example, what healthcare settings have been focus of the study included, and the rest you can see here. As framework and scope, well, rather than focusing on a specific architectural layouts like single patient rooms, as the first report in Swedish and the EBD 2020. This paper was anchored on a well-established healthcare quality indicators, the Institute of Medicine framework. So to define the outcomes of interest in this paper, and in the pre-screening stage, we referred to IOM. And IOM emphasized the importance of the built environment in achieving high quality standards and most of all, safe care. And the IOM framework includes 6 well-established indicators for healthcare quality. So guided by these indicators, we define the following 5 outcomes for our paper. Safe care, person-centered care, emotional well-being, clinical outcomes, and activities and behaviors. And our definition of environmental features was adapted from Harris model. I suppose that some of you are familiar with Harris model, and which include 4 categories of built environment: ambient, architectural, social, and interior. But in addition, a 5th category, nature, was added to address the impact of nature and the outdoors in healthcare design. Very quick. I said that it was a huge amount of articles, and our search strategy identified nearly 10,000 articles published from different sources. But after all screening, we ended up with 406 illegible publications. So that's the articles for the results. So now I will show you some pictures. you remember that we wanted to visualize the results in this mapping method. And this figure shows the geographical distribution of the articles by country. And you remember 406 articles or studies, or should I say where the study was conducted. Almost half were conducted in North America. It's very red here. I think it was 46% of the studies were conducted in North America, and with the majority from United States. And 29% were from European countries, with over one third of this were from Sweden or other Scandinavian countries. And studies from Africa were at least common and were published only since 2016, if I remember it's correct. One inclusion criteria was English. Maybe that's one of the reasons that we don't see South America in this figure. Many studies investigate person-centered care as their primary outcome in healthcare settings, while others examine safe care, emotional well-being, activity and behavior, and clinical outcomes. And you see the settings also here. Most of the places or settings were not more explicit described. This was more general wards. You have medical wards and pediatric and intensive care units. Very few studies were on palliative wards. I know that there are a lot of numbers here, a lot of colors and pictures, but this figure illustrates the categories of the design features in the studies that investigated different outcomes. And just to orient you, among articles that investigate activity and behavior, emotional well-being, person-centered care, or safe care as the primary outcome, the most investigated design feature was architectural features, followed by interior, ambient, social, and last nature. However, this pattern differed for articles that focused on clinical outcomes, with the impact of ambient features, mainly was acoustic environments such as noise and sound, lighting, such as daylight and artificial lighting, and smell being the most investigated, and nature features the least commonly investigated. And one of our questions was about method in research. I think we all have some thoughts about methods that we use in research when we study the physical environment or healthcare environments. If we take a look at our 406 studies, most included articles used, as you see here, quantitative methods, 229 articles. And of these, 39 reported experimental design, such as randomized controlled trials or case crossover studies. So for me, I think this is an interesting picture. You can say we observe. We are good at that type of studies. We observe and we talk to people, patients, professionals, significant others, but we don't do experimental studies. And I think we all know that, but this is showing us the numbers. It's easy for us to say it, but now we have the numbers. Here's another figure. The methods and design used varied based on the outcomes of interest. Here you see the quantitative methods were especially favored in articles that addressed clinical outcomes and safe care. Mixed methods were more prevalent in articles that investigate activity and behavior than in those that focused on other outcome categories. And you also see qualitative methods were more prevalent in articles that investigate person-centered care. That's also something that we probably knew, but we have the numbers now that confirm that we maybe knew already or think we knew. The last figure here, methods employed depending on design feature of interest. The type of method used varied somewhat depending on the main environmental design feature of interest, with quantitative methods slightly more favored and qualitative methods slightly less favored. And in studies that focused on ambient features compared to those focused on nature or social features, so to say. I hope you will read the paper later on, then you can really study these figures and numbers. So some conclusion before I end my presentation. The big question, what's the gap? Our findings provided several new insights, and to our best knowledge, this was the first review in which a large international and interdisciplinary team integrated the perspectives of both architecture and healthcare in the context of EBD. And this unique collaboration yields insight beyond, I think, conventional, maybe design-centric considerations, shifting focus from individual design elements to a broader consideration of health quality indicators, such as the IOM indicators in healthcare, provided a richer understanding of the research area. So, for conclusions, this review provides an in-depth overview of the existing studies on healthcare design research and sheds light on the current trends and methodological choices. While many articles focused on the prevention or management of infections in healthcare settings, like in the very first report, EBD 1, our review revealed a substantial evidence gap regarding atmospheres, art, and nature, despite emerging evidence that pointed to its crucial role in patient outcomes. And most identified articles were descriptive case studies that offered valuable insight into specific contexts. Nevertheless, further, more robust, rigorous, and evaluative studies are required to inform future planning and maybe also the design of healthcare facilities. And our review emphasized the importance of more analytical studies that focused on, for example, person-centered care and the impact of the built environment on patient outcomes. And we think that such studies will contribute to a better understanding of maybe effective strategies and interventions, and maybe facilitate evidence-based decision-making by researchers and policymakers. So we have the same base, we have the same database. We added we added a lot of articles after 2019. And we hope that this new database will be available for a broader audience. And I know there are some plans of that, and that it's something maybe we can discuss afterwards. So this is my last slide, and if you want to contact me, please, you can see my email address down to the left side here.
Thank you, Anna.
Stop sharing.
Thank you, Anna. Very interesting. Again, showing the importance of actually gathering information to get these views, which is a platform for actually knowing what we know, so to say. So let's hear from Italy. And what do you know? What do you say, Andrea? Over to you.
Thank you very much. Thanks, Göran, and all the colleagues that spoke so far. I will try to share my screen. Okay, I guess you can view it correctly.
Yes, it works.
So good afternoon, everyone. It's a pleasure to be here. I was supposed to speak together with Professor Stefano Capolongo, which unfortunately cannot join, but I will describe very briefly, in order to leave space for questions, some of the research that we are conducting at Politecnico di Milano. I'm a researcher and assistant professor at the Design and Health Lab in Politecnico di Milano, the Department of Architecture, Built Environment and Construction Engineering, and Professor Capolongo is a full professor and director of our department. In our lab, we focus on studies in the relationship between health and the built environment. We are both architects as background, but our scientific discipline in Italy, there are some classes for determining the knowledge and the scientific discipline in the national level. Our field is the public health. And the reason of this interaction is that Professor Capolongo has got a PhD in public health, and our entire sector is really looking for interaction between the professional of public health and hospital organization and the management and design of the built environment. We have been recently accredited by the WHO, by the World Health Organization, as collaborating center for healthcare infrastructures, planning, design, and developments based on the definition also of a technical brief together with our colleagues, also Professor Marco Gola and many other colleagues from the lab, about this interaction between the built environment and health outcomes, specifically regarding to new hospitals in the European region. We have several platforms where we develop research. One is related to applied research, and we have this support by companies and agencies and national and international levels in order to define the characteristics, the design strategies for the next generation hospital. This is a quite ambitious project where many topics are emerging, and we try to bring the research side, so we bring evidence on each of these specific aspects that, as you saw in the previous presentation, is not so easy. It's very complex, and we are never able to really grasp the specific indicators. So this is the next challenge. We also provide some educational activities, and within this educational experience, which is a postgraduate master, several students are coming from the medical field, from the public health. So many medical directors and residents in public health are very interested in understanding the role of the built environment. And it's exactly in this situation that we develop a research framework together with the two of the former students of this master, which eventually are a medical director in very important hospitals in Milan. We questioned ourselves about the characteristics of inpatient rooms, in particular for the Oncology Institute, the National Oncology Institute in Milan. Why this topic? Well, because in Italy we have a big debate in recent time about the characteristics of the patient rooms. We're still questioning a lot about the fact that is important to have all single rooms, a little bit of single rooms, double, multiple rooms. We have a regulation that provide us very few requirements, so the scientific debate is very active and the practical debate is very active on this, also because it has an impact on dimension, cost, and management in hospital environments. So within this context, of course, the focus was about this Oncology Institute and about the fact that we need to take into consideration several users, has been already said, but we have the patient, but also the medical staff and the nurses and all the staff that work in the hospital. Of course, we know from literature reviews, from theoretical background, the importance of environmental features and the possible influence of the usability of the space. So the fact is that the literature lacks some specific studies on the perception and with specific regard to the oncology environment in Italian context. And the objective of this study was to understand and discuss how the hospital environment has an impact on well-being and on preferences of patients and staff. So we conducted again an observation with quite a big sample of patients and staff, and also to raise awareness on the design and management of the hospital space. Why? Because this hospital is going to be moved in a couple of years to a new developments, and we wanted also to involve the staff in this process. So the focus will be on the patient room preferences. Of course, the survey and the study is bigger. There are many features investigated, but for reason of time, I will focus only on the results related to the patient rooms. And I hope we will publish soon this paper so you can read all the results. The foundation, the National Oncology Institute, is a comprehensive cancer center with an old monoblock with 14 floors and about 86,000 square meters divided with Deptartment as an organizational structure. The 171 inpatient rooms accommodate 464 beds, so you can already understand that the issue of single or multiple rooms is very important. We have 10% requirement by law of single patient rooms with between 12 and 20 square meters, 99 double wards, and 22 wards with 3 beds of 28 square meters. The methodology we developed was a survey-based methodology. We understood the most important attributes of the built environment within this specific setting thanks to a literature review, and a questionnaire has been developed and administered to the patients by Dr. Perotti and his staff, who was the medical director in the Oncology Institute last year. And after this submission, we decided to spread the same questions to the healthcare staff in order to compare the results. The survey has been conducted by Google Forms, so online survey, and 3 weeks to complete and return the question. The data were collected with quantitative and qualitative answer as well. The grouping of answers has been done in 3 classes: not important, quite important, and very important. And the target population was related to patient groups as a coherent group of patients with similar characteristics has been submitted on a voluntary basis to all the patients in ordinary regimen, both medical and surgical patients. And the results have been presented also to the coordinators and assistants. We've got 452 questionnaires with a balance in gender, but with a majority of people coming from northern Italy as origins. The questionnaires was also submitted to all employees with a significant length of service, and the majority of employees that have been always worked in this specific setting. We've got some qualitative comments with some insights on the improvements of space, on lacking of space, but especially we focus on this eternal dilemma between single and double room. We observe that within this sample, the patients do not have a specific preference on single or double bedrooms. We have more or less 33% of low, medium, and high importance of these specific features. What is interesting instead is to look at the response from the healthcare workers that instead, the majority of them, especially in the department of oncology, so the medical departments, they are quite sure that is very, very important to have single rooms compared to multiple rooms in order to make the work more efficient, safer, and also related to the relevance that there is in the medical compared to the surgical departments. Of course, we know that there are several studies on this topic, and experts know that there is evidence that confirm some results rather than others. But the situation is that in Italy, 10% is the minimum allowed by law. And if we made a survey on a big hospital sample, actually 13% is the average of beds in single rooms, while proposals in recent reports require the 80%. Of course, there are multiple strategies that we can use from single to double bedrooms to different space or to some micro examples, for example, in Japan. This study, of course, is still under elaboration of data. We have some insights also from the medical side, and of course the limitations are related to the fact that there is a limited experience. The majority of staff has been always working in this space, and probably we need also some specific analysis to some specific target users and target. There is a significant importance and focus on the evidence-based design principles, and we also were able to engage the staff in this direction. A greater importance of single room, even though the patients are not totally sure about this. They see some benefits also from multiple space. The future developments in this perspective is to since we have validated the questionnaire, to enlarge the sample, maybe at the European level, and also to develop some guidelines that could be applied at national but also international level in order to compare patients, users, and all the staff in the hospital buildings, also with this idea of assessing the qualities of healthcare infrastructure with KPIs and indicators coming from evidence-based design research. I thank you very much for your attention, and I look forward opening also the discussion and some replies to possible questions. Thank you very much.
Thank you, Andrea. And let's go back to sharing that one. Well, now talk. I also encourage those that are listening that you can, there is a Q&A channel, you can put in questions there. I know we're a bit short, but let's catch some important questions here. I would like to ask Mike a first question, actually. What comes after laughter? What's the second factor?
Well, one factor we are continually learning is that if you take care of your staff, the nurses, doctors, the cleaning staff, then they will provide better care. And I think that's something we struggle with finance for staffing, and also for giving them good environments in terms of how it looks nice, and it's safe for them, and it has daylight for them too. Those are all factors that can help.
Yeah. Okay, so keeping us, the human bodies, in good shape is sort of supporting us to do the work. And of course, the organizational input you bring up there with also, of course, the staff shortage challenge that we have. But just to get some more input from also the others, I was thinking of you, Anna, when you were talking about the research that we were seeing, how do we actually, we need more research, that was one of the conclusions, but how do we actually bridge between all the different studies are typically one case there, and one context there. So what's your idea about actually, how do we bridge between context?
You mean between the different contexts within healthcare?
Yes, I mean, if we study a hospital in Italy and in Sweden and in the US, how do we actually how do we transfer the knowledge so that it becomes useful? I mean, in biology or chemistry, you can move things, but when it comes to people in the healthcare system, how do you move that knowledge so it becomes equally applicable? What do you need to do with it?
First of all, I think that we could also see that when we looked at the articles and for these papers, I think we need to agree, not agree, but I think we should start with having some framework, for example, person-centered care, because now when we look at all these papers and very high quality research project, we can't really compare, as you said, Sweden with Italy and Italy with Brazil, for example. But if we could have some criteria or frameworks that we could start from, or have like a lens in our research, I think, for example, the IOM is a good example how an international framework for health quality could act to connect different countries with each other. We have, at least in healthcare, we have a lot of frameworks from the UN and from the WHO that could connect with the architectural and design research. And it could be easier to compare them. But that's my opinion.
Yeah, well, I don't think this is a problem specifically for just this kind of research, but I mean, in any research and study projects and study people doing things in cases, that's one of the challenges to all sort of contextual or case studies that are in a specific context. But I think that in healthcare and in construction and in architecture, we have so many of those. So we need to start finding a way of actually how to bridge that across and bring that across.
Could I comment that? I haven't said anything, Göran.
Oh.
Can I comment that?
Of course you can.
Yes.
I
think
it
was a really good question, and I think we can learn a lot from implementation science, for example. They are looking at projects how successful they have been in implementing in practice, and the context is really important to go a little bit beyond the results. So I think that is good. And I'm so happy that Andrea, that you are doing, and you, Mike, also are doing those kind of follow-up studies when you have built a building in hospital, because that is also knowledge, a good knowledge base. But it's a problem. I agree with you, Göran. And it's not only, I mean, you can also see that most of the studies are from OECD countries. So we have a lot of other important regions in the world that has to be involved in this also, or included in this also. Yeah. But we have a question from the audience also. But I want to come back to this about evidence later on and ask you and Mike and Andrea about that.
Yeah.
I think we have a question from the audience.
Yeah, we have, and it concerns how can we actually attract staff by the design that we have. And it's Henrik Bovin asks us here about seeing the increasing problem of finding staff. Has anyone looked at how different designs increase or decrease needed number of staff? I think we could give some examples of that. But let's hand over to Andrea first and see if you have any input on this one.
Thank you. I might. Thanks for the discussion. It's very interesting, all the comments, and just one consideration about the staff. Probably yesterday we were talking with some colleagues also about the robotics, the digitalization of healthcare, which will in the future, but not so in a short time, decrease the effort required by the staff. And for example, in Italy as well, we experience a shortage of medical doctors and also of nurses. But of course, this is due for medical doctors more and less for nurses, but is due to a, let's say, not so detailed planning of the medical university students, the residents, the specialization, and then the market. So probably is also a matter of time. In the short terms, there is not much to do, from my personal opinion. But in the long run, we need to get ready and provide our policymakers, our institutional stakeholders also data in order to base their planning decisions on space, on number of students, also on some evidence and reliable data. I think that in general, the space can help, the accessibility can help a lot. For example, in Milano, in the city of Milano, the hospitals in the city center, which are the ones that are more connected, they do not have a problem of staff shortages. But the ones that are more in the outer side of the city, the ones that have less accessibility or the ones that have less feature or less welfare have an issue of staff shortage. So probably architecture can influence the organizational habits, can influence the welfare activities for the staff and improve this process. I think in general, going back to the previous theme, it's interesting because healthcare has international standards in terms of clinical practice, in terms of, and we've been discussed with Mike a lot and other colleagues in our recent papers about international benchmark. But we need to provide some evidence on the fact that also healthcare infrastructures might have some international standards, because at the end, they accommodate some practice that have an international outcome. When I say standards, of course, it's not a prescriptive rule or regulation, but are some common considerations and design attentions that probably you should provide at the international level. This is our perspective.
Okay, thank you, Andrea. We're getting close to the end here. So I guess that the idea of how we attract staff to the healthcare is a big issue, because also, of course, how the whole healthcare system is a symbol for a good place to work for kids. I mean, it goes all the way into the schooling system. So a number of things here we could continue to discuss. So just a last question we got from the audience here, we might get to that the subjects that you mentioned before, Ásgeir, the ones that were actually in the report, is there any other new subject that is being emerging that also should be included? That is that staff issues, or is it any other issue? Have you distinguished colleagues here now, have you seen any other sort of theme that we need to bring into the next one whenever that report comes out? What should that team be? I think that's the last thing we can talk about today.
I don't know. I think the whole evidence-based field is a little bit threatened today, because I think we should protect inform-based research-informed design rather than coming up with a new theme. I think I will take a really good example. For example, there is guidelines that say that dedicated stroke units has to be built, a dedicated area for stroke patients, because it's improving patients' outcomes. And these units provide coordinated care, leading to reduced mortality and hence recovery and health. There is so much evidence on that. When recent trends in healthcare today, we have seen that it costs too much. So it has been a fragmentation of these units, and I think it will influence the quality of stroke care. So it's really important to argue even more strong about the evidence that we have today. I think that's among the most important thing, actually.
Yeah, I mean, I think as we know, it's 4 o'clock, so we need to wrap this up. But it's a good note to end on there, I would say, to actually sort of consider that we need more research, because that's basically what you are saying.
Yeah.
And now I have to go back here because I got all this. I got us in front of this. Can you see the slide now? This is show this. Do you see the slide now? Thanks.
Yes.
Okay, good. I want to be sure that you can see the links there. So again, thank you all for participating. I think we ended on a note there that we need to really evaluate and do more with the research and we have and the data we have, and continue to actually look about so that we sort of continue with evidence approaches and with research-based approaches, and that we do not let that become just a management term, but actually a proper design process term that actually brings best for care into the designs. So again, thank you all for being here. Thank you all listeners. We were around 60 that listened into the session. It was good to have you all here, and thank you so much everyone that participated here in the discussion at the end. I'm sure this is not the last time we see and meet each other concerning these issues, but again, thank you so much for being here today.